boldly engaging the mindless propaganda of our time, apparently with reason. This is Rage of the Age.
This is Rage of the Age, and we have with us a graduate of the University of Missouri, the Kansas City Medical School. He is board certified in pain management, anesthesiology, and age management. He is also an entrepreneur and real estate investor. I want to introduce to you today Dr. Gurpreet Padda. Welcome to the show.
Thank you so much. I really appreciate having me on.
It's interesting that I have you on today because what drew my attention and thinking to myself, I want to have this discussion today on this episode is a comment you made that there are a lot of physicians and doctors who are not financially prepared. And you've said that many of them face bankruptcies and things of this nature, which catches me off guard because I'm sure, like myself, there are many who are listening who are thinking, well, I thought doctors made all kinds of money. How are they going into bankruptcy and why? How is their money trouble? So why don't you lay the groundwork for that there? Why do you see this difference that maybe others perceive?
So I think that most physicians think exactly like you do. There's no way that as a physician, I'm not going to make enough money. And so here's what really happens. People go to medical school for a long period of time. They sacrifice their money. They sacrifice their time so that they can take care of patients. And they educate themselves deeply on medicine. And at the same time, they're sacrificing the other skills. So they lose the skill of dealing with society because they typically are so narrowly focused on trying to help people. They themselves lose some of these societal skills. They lose the ability to collaborate in a large group. The physicians typically tend to be lone wolves. They tend to educate deeply, and they're judged on their individual skill. So they typically tend to be less reliant on the group and more self-reliant. And we're educated at a very early age that you're supposed to sacrifice all of this stuff to help your patients, and you're supposed to give of yourself to society. And in that process, money is a bad thing. And I've talked to hundreds of physicians, and I always have this conversation, and they think that the hospital administrator is the bad character because he makes money. No. And physicians intrinsically believe that money is the root of evil, that money is something that should not be pursued. And really, it's for the greater good of society, they should live this amazing lifestyle and they should be rewarded for it. But the problem is they leave medical school, they're poor, and all of a sudden they are in residency, they finish up, and they have some money. And then they start spending like crazy, thinking that they're always going to have money. But the reality is, if they get injured, if they get sick, if they themselves have a problem, most of them have less than 2 to 3 months of cash. The bankruptcy rate amongst physicians is at the same or higher than it is in the general public. And if you look at physicians, they die broke just about the same rate as everybody else that dies broke. And so they just have more money, but they have bigger expenses, and they never learn to manage it in the first place. So they're more likely to get themselves into deeper trouble faster. It's like having a Ferrari and not really knowing how to drive it, and then crashing it.
That'd be a monstrosity.
Yeah.
So what kind of overhead are we looking at to be a physician in that takes away from a lot of that income?
So, the reality is that most physicians graduate with $150,000 to $200,000 of student debt, and they pay that back. Most of them, if they run their own practice, run on a margin of 5 to 10%. So their practice might make $1 million, but they might only get 100,000 out of it. And physicians are taxed at one of the highest rates. They're professionals, they're W-4 workers. And so those taxation structures are between 38 to 45%. So at the end of the day, they're working hard, but they have never been educated on money, and they're paying most of their money in taxes, and they don't know how to shelter that income. And then so they rely on the things that they're, what little they do know, and they typically invest in things like the stock market, or they invest in their friends' XYZ thought. And, physicians tend to attract predators because predators know that physicians have money, and you can easily separate somebody with a lot of money from their money. And so they attract people that look at ways to separate the physician from their money. And the physician, I have to tell you this, I mean, the reality is that physicians have a slight narcissistic personality. You couldn't be a good physician and hold yourself out if you didn't believe in yourself. And the more you believe in yourself, the more narcissistic you become. And sometimes it becomes pathological. But there has to be that slight amount of, I know what I'm doing. And sometimes that doesn't extrapolate to every field. It may extrapolate to your medical field, but it may not extrapolate to your financial field, or learning how to deal with people, or learning how to negotiate, or learning how to do your taxes. And so it's that those blinders that gets them in trouble.
I believe in many lines of work, especially with people working in their passion. Many people have no idea about like the things you mentioned, how money actually works, how to shelter certain taxable income, making connections. Because I know, like when you mentioned in your head, self-reliance, I'm thinking to myself, there's many Americans that are going to say, well, that's a good trait. Self-reliance is something you need to fight the struggle and to get through to the end. But you're mentioning things that I think are neglected. I believe early from our educational system kind of pushes this idea, but you're talking about things like, connectivity and connection and building networks and how to manage your money. Because you said people prey on doctors on purpose. As a group, are they really unable to see it coming to be separated from their money like that?
Yeah, because they're so into their own, and I'm a physician, and I know how this works. So most physicians are so focused in on taking care of their patients and the medical stuff, they accept compliments. And I'll give you a classic example. How is it that drug companies send people into physicians' offices to get them to prescribe? They compliment the physician. They come in, they provide lunch, and they tell the physician what a wonderful job they're doing. And compliments will get you anywhere if you have a little bit of narcissism. And that's how you feed into people's behavior. You compliment them, and you repeatedly compliment them. And that's how, and you mirror their behavior. And physicians don't get that. They don't understand the psychology of the compliment. They think this person genuinely thinks I'm a good guy. Well, the reality is this person is being paid on a performance basis, and they've discovered that the way to get you to like them is for them to compliment you. And so physicians don't grasp that concept. And that's why I banished all drug reps out of my practices. Right when I left medical school, right when my first practice I started, I banished all drug reps. I'm like, no reps shall ever step foot in my clinics, because I know for a fact that that's a manipulation. If I really wanted to get the information, leave it for me in an informative package that I can read, and I can go through it, and then I can ask questions, and I can dive deep into it without all of the fluff, without all the compliments, and without all the food and those things. And so that's the kind of stuff that we're missing. I mean, the thing is that physicians, they can't leverage themselves. And so there are three things that I really look for in everything that I seek out. It's how much time, how much money, and what's my strategy. And if I have money, I can buy other people's time. Physicians can't buy other people's time to replace what they're doing, but they make money. And so, from a business standpoint, what I tell physicians to do is take the money you're making and buy other people's time as an expertise to help you develop the strategy that might work. And you might have to pay a little bit. You might have to in order to get somebody that you can trust, but don't let just the fact that they're complimenting you be the driver for why you execute a strategy. And so that's the kind of stuff that when you get into dealing with physicians, those are the kind of things that you have to think about.
Absolutely. So did you have like an army of drug reps, like a cloud of locusts constantly descend on your practice that you had to like say, no more, y'all get out? How bad was that?
2 to 3 times a day, people would show up at our practices and they would try to give you gifts. They would try to give you food. They would try to bribe themselves in through your front desk or through your back desk. And so we put a specific prohibition in place that didn't allow that. And we put up signs and they would still try to sneak in. And so we finally figured out a methodology that and they hated me for it. But what it did was that it kept us from prescribing medications that were non-generic. It kept us from wasting time on a social basis with people that were looking out for their interests, but not necessarily for our interest. And it also, it keeps you from making a bad decision. Because if you're being swayed by somebody coming in and talking to you, and it's not truly educational information, you might be doing the wrong thing. You might be picking a drug that's 8 times more expensive than it should be. You might be picking a procedure that's 5 times more expensive than it should be because someone has suggested it to you. And that's something that we want to avoid if we can.
Because you said the information about these medications, they could just present it to you, or are you able to like find out this information not going through them, or are you kind of like tied to them for this information on how a specific drug works?
My preference is to go to my journals and read through those journals. And you have to realize that, and I'm going to say something that will probably upset people, but the reality is that most articles published in the medical literature usually have some funding or backing somewhere by some company that was in some way peripherally supporting them. And that doesn't mean it's bad. It doesn't mean it's good, but you have to recognize that there's always going to be some bias because the negative studies, the ones that showed that the thing didn't work, will never get published. And there's an inherent bias in the publications. And there's a further inherent bias if you rely on the sales rep because their job is to sell. Right. And so my preference is to cut the sales rep out and go to the principal journal and then try to understand the journal information and then compare it to existing technology and existing methodology. And so I try to go one step before them.
Right. Is there a counterbalance to a biased journal, if I could say it that way? Or are we kind of stuck with that right now?
What happens typically is a very positive article will come out and people will study it again. And then a mediocre article will come out and then people will study it again. And over a couple of years, you'll get sufficient information that really tells you and validates whether that was a good idea or a bad idea. And then you'll get people that will criticize the concept and then people that supports it. And then at the end of the day, you do something called a meta-analysis, where you aggregate studies, you aggregate groups of studies that may not all be funded by one company. You aggregate those studies together, and that really gives you the evolving science. So it's an iterative process over time. If you relied on the first study that ever came out on XYZ drug and you said, this is it, you'd probably make a mistake half the time. And there's so many drug recalls that happen over time because we learn more about it. And we learn that it has an unintended side effect, or it doesn't work as well as we thought, or maybe it has a side benefit that we were unaware of. And so over time, a lot of the drugs will change in their application and their usability. And those are iterative processes.
Well, that's sort of how I would picture a doctor being able to analyze data, to test the data, make empirical observations, keep going over different findings and materials and testing them again to where you get a more refined knowledge of what you're looking at. And I find it intriguing that skill is perhaps applied very well in the medical field, but when it comes to things like finances or any other social aspects that you were talking about, it's like missing. What is it? Is it because it's just such a narrowed in view of things and blocking out everything else for efficiency's sake, or is there what accounts for that, you think?
It's the hyperspecialization. So people that typically go into medicine don't usually go into it from a broad field. And they typically have become science nerds. They become very hyper specialized, and they very narrowly focus. And it's like they build that one muscle and they ignore the others. And so one of the things that you want to look at when you look at physicians, and they become so specialized that they don't even know the specialty next to them. It may still be medicine, but the pulmonologist may not know much about renal disease. The renal doctor may not know much about, brain health. And the brain guy may not, the neurosurgeon doesn't probably know a heck of a lot about liver pathology. And so you become so specialized in that field. You're really, really good, but you ignore all of these other things. And you do it at your peril, because the reality is that one thing that you're really good at in medicine may not translate to wealth. It may not translate to a long-term stability. It may translate to there in that particular field, but it doesn't necessarily translate to a retirement, to sending your kids to college, to living the life that you want to live. And it may not translate in your ability to do free social care that you may want to do, but you can't afford it.
Do you believe then that our doctors are sufficiently compensated for their specialities and their hyper focus?
Yeah, I think so. I think that U.S. doctors probably make the most amount of money in the world as in terms of physicians. There's no doubt that they make a lot of money. What differentiates here is that we are over specialized. And during that over specialization, we lose some of our general skills. And it's the loss of general skills that's a problem. And it goes back to our educational, our primordial educational system, the educational system that we have from children going forward, the educational system that our parents teach us, that we start with, that looks at money as a zero-sum game, and it looks at wealth as something that you don't want to aspire to. And it looks at an egalitarian socialist system that capitalism may be a bad thing. And when you think of money as a zero-sum game, that if I make money, you make less, then socialism says, everybody should make a good amount of money. And then you don't necessarily reward a particular skill. So, but if you look at money as I make more money and I bring the entire society up and the society gets wealthier overall and our lifestyle overall improves, then it's a different world. And so one of our main issues is that we don't teach our kids at a very early age how money works, what money is. And, we have a fiat currency. We can print all the money in the world. It doesn't make much difference. And I don't recommend that we do that, but it's a fiat currency. And so my feeling is that we really need to educate kids at a very early age about financial health. We need to, it's one of those principal things. It's an econometric thing that we should be teaching. And it's the one thing that little kids know nothing about. It's the one thing that 3-year-olds don't understand. Even puppy dogs can count. Even, if I give one dog 2 treats and the other dog 4 treats, the other dog that gets 2 treats wonders, why didn't I get the extra 2 treats?
That's right.
And so even animals that are fundamentally basic understand the concept of mathematics, but but they don't understand the concepts of storage, and they don't understand the concept of investment, and they don't understand some of these other higher concepts. But but even little kids understand mathematics, and it's something that we don't push to teach them.
I hope you're enjoying today's episode. If you really like Rage of the Age, we will encourage you to leave a review on the platform that you're listening to, but especially if you would like a copy of my book, Not in the Wind, Earthquake, or Fire, which is a first-hand account of my second deployment to Iraq, and it's filled with many spiritual insights. I'm going to give away 10 copies for free, and every week I will give out a copy for someone who leaves a review of this podcast. You can do that by going to Twitter, write your review, and then hashtag it Rage of the Age Now. Or you can go to Facebook, find our page, Rage of the Age, click the reviews, recommend us, and then write in your review. I hope next week to give away a copy of Not in the Wind, Earthquake, or Fire to someone who leaves a review.
You're listening to Rage of the Age. Rage of the Age. Politics, religion, economics, and history with a conservative bend.
You started, I don't know if this was initially just this thing, because you said you have multiple companies, but you have a Red Pill Capital, which deals with real estate and investments and things. You stated, I believe you said you had several hundred multiple family units that you particularly have, over 2 million feet of commercial space. You have ventures in real estate syndications, about 100 multiple family homes. And one of the things that you've stated as to why you wanted to do this was to help my fellow doctors attain financial independence and practice medicine on their own terms. Is it hard for a doctor to practice medicine on their own terms today?
Yeah. And it's actually gotten a lot worse in the last 3 to 4 months. So we've had a historic decline in independent medical practices. Most physicians, I would tell you, almost half of them now work for a hospital. And during COVID, the practices that got the highest amount of injury were the independent medical practices, because they really couldn't see patients in clinic. And a lot of the procedural specialists who do elective procedures couldn't see those patients either. And so the COVID crisis is going to cause a centralization and further centralization of medical care toward larger and larger entities like hospitals. You'll also see the same thing with laboratories. You're going to see the big lab groups become more and more centralized, and the small lab groups falling off. Anytime you have this kind of cataclysm, you will get the people with the financial depth will do better than the people without the financial depth. So you're going to see this concentration occur. It was already going on. Physician practices were already devolving. They were independent. And so I see this getting a lot more significant. Physicians, by their very nature, cannot leverage their own time because they're providing direct patient care. So you can't take me and have me do 2 procedures at the same time or 4 procedures at the same time. I can do that on a financial basis, and I can do that with leverage on the business side, but I can't do that on the medicine side. And so we're getting a concentration effect that's going to occur, and it's going to get worse. And so physicians will not be in the same boat that they were in the previous iteration. The other thing is, if you look at unemployment rates, physicians historically have a practically nil unemployment rate. They can find a job anywhere. But all of a sudden, the unemployment rate amongst physicians is hitting 8 to 10% all of a sudden. And you would think in a medical emergency situation, you wouldn't have any unemployed physicians.
Yeah,
but you have 8 to 10%. Wow. And that's interesting.
Yeah, it's very interesting. So you're talking about centralization of, I guess, healthcare in general. And and that's impacting how the doctor can do medicine on their own terms. Now, when you state that, doing it on your own terms, what exactly do you mean by that? Are you talking about financial independence, or are you talking about what they can actually do as a doctor? Can you be more specific about that?
What I mean by that is what you can actually do as a physician. So, for example, I do about $1.5 million a year of free care because I want to. I want to help patients that have no insurance. So I do $1.5 million of free care, and I run a reversing diabetes center. And I take patients who are 450, 500 pounds, and I get them to change their dietary behavior, their behavior towards food, their behavior towards exercise, their behavior toward medication. And over the course of a year and a half, I can get to, if they're type 2 diabetic, I can get their type 2 diabetes reversed, and I can get them to lose a ton of weight, and I can increase their functional activity. And many of these patients who previously couldn't leave the house actually go back to work. They go back to function. And that gives me incredible joy. I couldn't do that if I was working at the hospital, because the hospital wouldn't support that. You know, if you don't have insurance, you're not going to come in electively to utilize hospital facility to do that. Now, they may do it as a nonprofit, and they may do it out of the goodness of their heart, but then I have to go for approval for that. I have to beg and plead with facilities to allow me to do that. But if I want to run it on my own terms, I can do it anytime I want. If I wanted to look at a better way to treat headache patients, and I thought, I've read the study and this is a good idea and it's very, very safe and my patients would benefit from it, then I should consider this as an option. And so those are the kind of things that I think are worthwhile. And those are the kind of things that I think benefit my patients. And you can't do that necessarily at a hospital.
I certainly agree with a lot of what you're saying. Can you pinpoint some of the obstacles, I guess, in the way that, if you was allowed to make changes to our healthcare system as it is, as the whole system, what would be some of the things you would tweak or remove or change to allow doctors to actually have a more freer practice of their craft of medicine?
Well, so I'm going to change your question. So let's start with, what would I do about medicine in general? Okay. And what would I do that would save us $1.5 trillion a year and is involved in probably 2/3 of our medical disease and is the leading cause of hypertension, the leading cause of obesity, and probably the leading cause of tumors, of cancer, of solid tumors. And that's dietary impact. The first thing I would do, if I had my way, is I would go back and re-engineer dietary impact and look at the way that we eat food. And if you change that, you could eliminate the need for 1/2 to 2/3 of healthcare in the United States. And we would all be healthier, and we would all be skinnier, and we would all have less likelihood of developing Alzheimer's, and we would all have less likelihood of becoming diabetic. So if you look at the Joslin Institute is the Diabetes Institute, and you look at their historical archival records, the incidence of type 2 diabetes was almost negligible in the 1900s. And it didn't really start to climb till 1930, 1940, and then it really jumped in 1978 to 1985. And it mirrors the obesity epidemic. It mirrors the cholesterol issues that we notice, and it mirrors the hypertension, and it mirrors the cognitive decline. So we have a commonality that we have something that's going on, and it's this pandemic of diet is going to kill way more people than the COVID pandemic. The COVID pandemic will come in as one of the top 10 causes of death in the United States. But our diet is probably cause 1, 2, and 3. And so if given the choice, I would change our relationship with food. I would change our relationship with large food manufacturers. I would change our relationship with how we produce and consume. And I would have us get away from processed foods. I would have us get away from vegetable oils. I would have us get away from sugars. If you did that, we would have a massive change. And then with respect to physicians, a lot of this falls away if you don't need ICUs as much. If you don't need to put the patient in the hospital and you can run this as an outpatient world the vast majority of times, then everything else disappears. If your ICU is built so that you can treat diabetic patients who need amputations, and your operating room is built to deal with gunshot wounds and penetrating traumas, if you change the underlying causes, you don't need these large architectural elements, and then it changes medicine. It changes. It's a domino effect. The reason why our hospitals are so big is because we have need for very complex care. In this medical industrial complex, we have need for this extremely complex care because we have a very sick population. If our population isn't as sick, we don't need this centralization, and we can treat at a more fundamental level. And I don't think that anybody would disagree that eating real food is better than eating processed food. And the more real the food is, the more connected we are to our food supply, the better off we are. And so that I would start there, and I think the rest would take care of itself over time.
Oh, wow. Okay. So you say what, from 1930s on, it started to escalate?
It started to go up, but it jumped in 1978 to 1985.
Wow. And what are the correlating factors? I'm assuming you're saying it's diet. What particular things did we start eating that our ancestors didn't have much of, that just suddenly spiked those rates?
So there's a couple of factors. One of the main factors is the consumption of omega-6 fatty acids, which is vegetable oil. So we started getting vegetable oil into our diet with really the use of Crisco. And I'm not picking on Crisco specifically, but I'm just saying that was which is a way to hydrogenate liquid oil. What they did was they figured out, they got a patent that allowed them to make liquid omega-6 into a solid. And that's how you got Crisco. You got this white, creamy stuff. And then Crisco wanted to sell as much Crisco as they could. So they started sending out cookbooks to housewives and saying, you don't want to use this lard. A modern housewife doesn't use lard in her pies. A modern housewife doesn't do this, doesn't do this, doesn't do this. And so they gave out free cookbooks and specifically targeted people to make them feel more modern by avoiding animal products, by avoiding lard and avoiding butter eventually. And we started to incrementally increase our omega-6 fatty acid consumption. And then canola oil in the late 70s was the next big jump. And they modified canola oil, and we ended up with a ton of polyunsaturated fatty acids that are incredibly unstable in light, unstable at temperature, and create a lot of free radicals. And so that really jumped in the late 1970s, 1978 to 1985. And so you can see each time we've increased our omega-6 consumption, you get a dramatic jump in liver dysfunction and insulin resistance. So that's factor one. Factor two is our overall consumption of sugar. It used to be that our fruits didn't have much sugar in them. If you look at our grapes from 1880 to our grapes today, they're nothing similar. You can take a glass of grapes, squish it down, and you get the fluid out of it. It has the same amount of sugar as your soda does. And that's a big change, because before it had a lot of fiber in it and it didn't have that much sugar. Now it's so sugar sweetened because we've modified it. And it's not some fancy genetic engineering. We've selected varietals that produce greater and greater amounts of sugar concentration because our palate is engineered for that. And at the same time, we have a society of hyperconsumption. And so what that means is these big food manufacturers try to trick us into consuming more food. And I'll give you a classic example. Let's say if I was an animal foraging, and this was, the 1300s or the 1100s, And I ran across something that was really tasty and just had a spectrum of flavor that I just loved. I would seek that out and eat more of it. Well, I couldn't find much of it because it usually was of limited quantity, and it took me a lot of effort to get it. Now I come into the year 2020 and I'm an animal at the grocery store and I find a bag of Doritos, which is really easy for me to get. So I didn't have to spend a lot of energy to get the Dorito, and it's really, really good. And all of a sudden, I don't want just one Dorito. I want to eat the whole bag. And they've engineered the food inside the Dorito bag to have different flavor profiles, so my tongue doesn't get used to a particular flavor. And I keep eating more Doritos because there's a variety of flavor in the same bag. They've engineered it so that you don't get palate exhaustion. And so the big food manufacturers have specifically engineered our food in such a way that we want to consume more and more of it. And the flavor engineers have done an amazing job at getting us to eat more. There's actually a book about this. It's called The Dorito Effect. And a lot of these food engineers came out of the cigarette world and went to the food world right when we made cigarettes less palatable for American society. And so a lot of them are now migrating from the food world to the marijuana world. So I would suspect that we're going to have varietals of marijuana that we've never seen before. They're going to be modified in such a way that we are going to want more and more of it. And so you can see a transition effect.
Yes. Well, one of your specialties is addiction, and you were once on Fox 2 Now in St. Louis, Missouri, talking about the use of CBD oil and how it's different because it comes from hemp and not from marijuana itself, which has more effects on the brain and giving you a head high. Do you have a concern with the marijuana industry, I guess I could call it now, big marijuana perhaps, trying to make things addictive like they've done with these other things you've mentioned that could have severe health effects in the future? So
I have a little different viewpoint about addiction. And so I mentioned these things that tell you that things are more hyper palatable. Yeah, I have concerns for all primates that interact with all substances. But addiction is more than just the interaction. And let me give you an example. So we knew that during the Vietnam War, there was a great utilization amongst people that were in theater of heroin. We knew that there was a lot of heroin usage. And there was a presumption that when these people came back from Vietnam, we would have zombies on the street walking around, and 60% of them would be doing heroin, and we would have this huge problem. Lo and behold, they came back, and only about 3 to 5% of them had a heroin addiction when they came back. They were able to give it up. So that poses a question. Why is it that the animal will use an addictive substance when it's allowed to use it, but when it's not convenient for the animal to get it, it won't use it? So there was a study done on rats. And the initial part of the study was they put the rats in the cage and they allowed the rats to hit a bar and get a sip of, I believe at that point, the initial study was done with a morphine equivalent. And they allowed the rats to get morphine. And the rats passed out, and many of them died because they kept hitting the bar to get higher and higher and higher, and they died. They redid the study. And they said, instead of just putting the rats in a cage, we're going to put the rats in a cage, but we're going to put other rats in with them. And we're going to let the rats play with each other. And we're going to give them an enriched environment. That's what we're going to call it. We're going to call it enriched environment. So they get to have sex with other rats. They get to run on a Ferris wheel. We give them mazes, but we're going to give them the same opportunity and access to this morphine water. Lo and behold, the rats didn't die. They were so busy playing with other rats that they didn't care about the morphine. And so these are the same rats. Some would die if they were lonely and didn't have anything to do. And the ones that had other things to do didn't. So intrinsically, yes, if you give somebody a more addictive substance, they're more likely to consume it. But I don't think that the addiction rate's going to change. I think the addiction rate's going to be the same. as long as societal pressure allows people to interact. I believe that addiction is a disease of loneliness. It is more a disease of loneliness than it is a disease of the drug. The drug is important. You have to have the drug in order to demonstrate the addiction. But the underlying issue is the loneliness of the individual. And our biggest problem with addiction management is we fail to treat people with respect. We fail to treat them with dignity. We don't give them the kindness, love, and compassion that they need. And we push them further into loneliness. And pushing people into loneliness only causes them to be more addicted. And so that's my take on it. And I deal in the addiction field. I deal with interventional pain. I deal with addiction, and I'm actually boarded in addiction as well. And I fundamentally believe that yes, the marijuana industry will manipulate their medicants so people will buy more of them, but it will be the same people that will consume them to excess as would be lonely, as would have a social isolation. Now, that's another problem with COVID, is that we're all socially isolated, and it's getting worse. And our actual addiction-related deaths have climbed 15% month over month over month while we've been in this, whereas our prescription of narcotics has declined 10 to 15% month over month. Wow. So our prescription narcotics have gone down, but our deaths from addiction, from drug overdose, have gone up. And so that's a very interesting thing, that people are getting less medication, they have less access globally, but the people that are dying at a higher rate. And so to me, that tells you that, again, it's not necessarily the medication, it's what the person is doing with the medication in the milieu of their personality.
That's very interesting. Wow. Now, in that interview with Fox 2 Now, you said, I believe you use CBD oil to treat patients with addiction as a way of weaning them off of, I guess, whatever it is that you're weaning them off of. Do you coordinate psychological evaluation with that to help with the loneliness?
Yeah. So our program that we deal with addiction is a combination program. So we use everything from ketamine to CBD, to psychological intervention, to behavioral intervention. We find that many of our patients with addiction have an underlying PTSD. We find many of our underlying patients with addiction have profound other issues and very difficult social situations. So you really need to get to that. And at the same time, you find that they have a ton of neuroinflammation, and they lack coping skills. They feel hopeless. And so you have to get to that, and you have to understand their hopelessness, and you have to understand how to move them from point A to point B. You can't do it directly. They have to do it, but you can give them the tools that they need to do that. You find a lot of attachments that they relive. So, and I'll give you a classic example. I was dealing with a patient literally yesterday, and he has an addiction, and he also has a crush injury because he got crushed by a truck, and he also has an underlying issue of an ex-wife. This patient has an underlying issue that's very, very significant. And what I did with him was that I walked him through a ceremony. It's called Ho'oponopono, which is the Hawaiian ceremony of forgiveness. He needed to separate himself and forgive his ex-wife. We walked through that ceremony so that he could then cut that quantum link. You can change addiction if you can change the loneliness. And if you have an attachment to something in the past and you keep reliving it, you can't form new attachments. Sometimes you have to cut the old. And so I know it sounds hokey, and I know that some people will go, well, that's completely foolish, but it's true. I mean, human beings are very fragile creatures. and we carry a lot of baggage.
Yeah.
And we have to understand that baggage. And you're not going to understand it unless you can do something with it. And so that's part of what we did was we worked through those issues with him.
Wow. Dr. Gurpreet, I appreciate your time with us today. Some very interesting topics that we talked about. We could probably go about this probably another hour or two, all the different aspects that you bring up. Very interesting with the idea of addictions, the dietary impact on our diets, that doctors have a difficult time with their finances, different aspects of how you see the medical field. I definitely appreciate you sharing your insights with us today.
Sure, absolutely.
Welcome to the question of the week. Last week's question of the week was, what do you think of current American business management methods? And I want to highlight a response by Christopher Van Am, who said, a lot of people making various rules and regulations to justify that they have a desk and a cup of coffee. I'm pretty sure there are many of you who go to work, who have a boss, and that pretty much is your expression. Why are you the boss? Why do you have that job? Why does your job even exist? And why should I have to listen to you? Very interesting observation. Definitely something I think businesses need to think about for the people that they hire to be the bosses. This week's question of the week is this. How much control should government have over health care? I'm going to post that question on Twitter, Rage of the Age Now, and I will post it at Facebook on the Rage of the Age page. Comment on that question. I will highlight a response from next week. Again, the question of the week is, how much control should government have over health care?
You're listening to Rage of the Age. Rage of the Age. Politics, religion, economics, and history with a conservative bend.
Welcome to the essay segment for this episode. Talking with Dr. Padda has definitely made me think more about our medical system within the United States, the way things are going, especially now with the coronavirus, the COVID-19 virus, and all the politics that's revolving around just that issue alone, much less other issues. And I've been digging in a little bit, thinking about the interview I had with Dr. Padda and the things that he said. Some very interesting insights. I really enjoyed that interview, but I was thinking on the grander scheme of things within this nation, just things that are just, I don't like how they look. I don't think a lot of people like how they look, but they are an unfortunate reality, really. And I was looking at some situations and stats, especially concerning the COVID-19 thing. And according to the Associated Press, there have been 49 state and local public health leaders who have resigned since April. And that number might have even gone up since that one has been put out. But 49 state and local health leaders who are public leaders, they have resigned since April. And that has actually accelerated since like June. As it's gone on, those numbers have accelerated even quicker. And the main reason is they're fed up. They are in a politicized environment where they're expected to provide results that people want to hear as opposed to just giving the data that they have. And to be fair, some of them have been fired due to the way data had come across, and it led to false conclusions because certain things weren't turned in time, or the numbers were just wrong in a certain case. And so in some cases, maybe they should have been fired. I'm not saying they shouldn't or shouldn't have, but some of them they claim they've been removed because they didn't provide the results they wanted. Some claim they have been removed because, look, I'm working with the equipment you give me. You don't pay me enough to do this job. We're still using fax machines. Hey, welcome to the government. There you go. I remember not too long ago, I was in a DMV, and they demanded I pay by check or cash. I couldn't use an actual card at the time. That's the U.S. government. They do not keep up with the times whatsoever. You work with substandard equipment, the end, right? And they're like, look, I have this equipment. I'm giving you the best I can with what you give me to work with. Not good enough, you're fired. That's a bad circumstance too. But then you've also had doctors who have come out publicly about certain things regarding the COVID-19 issue. And there had been backlash against them, where they would come out with this statement. And I'm thinking of those two doctors who were running the urgent care, the health care. They came out with their video, went viral, and you had this jump back on them, with accusing them of trying to just get attention to go viral. They're not giving good information, sort of thing. It's biased information. And it was instant slam on them just for bringing out, what they were saying. There's people like Dr. Ming Lin, who was removed from working at a hospital in Bellingham, Washington, where all he did, and that was back in April when this stuff was really coming out full speed. We didn't fully understand where it was going, and everybody was scared to death of it, everybody. And he expressed concerns on social media about not enough precautions being taken. They're dealing with the staff, but not necessarily the visitors. And he just expressed that concern. And basically, he was fired. I mean, it's worded like, well, the hospitals there will say, well, he doesn't work for us directly. But, in the end, he don't have that job anymore, right? He has to go somewhere else. So you can sugarcoat how you want. There was a reaction against him simply because he went public about something that he, as a doctor, he was saying, I don't think, our precautions are good enough for this. And he was let go. That was back in April. Now, there's a closer example of Dr. Simone Gold in California. And this was just towards the end of July here, not too long ago. Was fired for appearing in a video supporting the use of hydroxychloroquine. And she's made a statement that doctors are being overruled in treating their patients by governors and pharmacies. And her whole thing is, I just want to practice medicine as a doctor, but you all are trying to stop me every step of the way from actually doing it. And her insinuation is because you want a certain political result. The charge I see from a lot of angles, it's written by different perspectives, of course. Some celebrate when somebody gets fired. Others see it's a political thing. And each side of the aisle, if you will, is accusing the other of doing it. And yet I see both sides are doing it. And it's made me think about this quite a bit. They each are screaming that it's not fair that the medical field has become politicized. Even though in some cases they want it politicized, and they just resent when the other side exercises their political clout in that same arena that you're doing. I think people are mad they don't have a monopoly on the health issue because it's so important to many people and they see political leverage there. And I think that's a true frustration just for a lot of people. If the other side gets the upper hand, well, it must be politicized. Well, you're doing it too. It's happening on both ends. But this is the thing I was thinking about, though. It is politicized greatly. It really is. In fact, the hospital that Dr. Simone Gold had been affiliated with, at least in the reportings, put out a statement that we didn't hire her directly. She doesn't work directly for us. She's sort of outsourced. Dr. Ming Lin in Washington, he made that statement too. Like, look, I didn't work for them directly. I'm outsourcing. And that hospital in California, we said, look, we're not allowed to hire our own physicians in California. And I thought about that for a moment. How politicized is that a hospital is not allowed to hire their own health professionals? That's done through somebody else, probably with government oversight. You can't say and complain that the health field is politicized when you have the government with a healthy overreach in how it's conducted. If you put the government in something, the natural result is what? It will become politicized. I don't even know why I would have to explain that to anybody. It's a natural result. You put the government in something, it becomes politicized. And not only does it become politicized, it becomes governmentized. Our government is the most inefficient entity in the whole of our nation. I trust it to run absolutely nothing and to do it at the best they can. It just can't do it. And the reason is because they do just enough to look like they're doing their job, because they know if they overshoot something and it looks wrong, then somebody's going to try to clobber them politically, so no one tries hard. You just do what's required and say, well, I'm doing my job, and yet if your political opponent does that, you then turn around and say, you're not doing enough, but you won't either. Those who complain you're not doing enough, I'm calling you out. You don't either. No one does. That's the nature of government. You do the bare minimum. You take your quick claim of victory and you accuse your opponent of not trying hard enough. And when both sides are doing this, well, it affects the thing that's being fought over. In this case, it's health care. The government has gotten its hands so much into health care, it has politicized it. You can't look at it any other way than that. When the government gets involved, especially with federal dollars, it changes the way business is done. That's simple economics. It's simple politics. The government gets involved and it becomes very politicized. So you have hospitals that cannot hire their own doctors. Why? I cannot possibly imagine. So a hospital can literally be given physicians they don't like, and it's basically tough. You got to deal with it. Oh, but hey, the bottom line on the dollars, that's your problem, right? You have doctors who, out of frustration, go public about things because those around them are trying to corner them into certain conclusions, and they don't want, we don't want our, entity looking bad. You've embarrassed basically a manager or a governor or some kind of official, and they don't like you for it. So they come back at you. Well, that's politics for you, right? And this is something I think we seriously need to think about. If you hate the idea that the medical field is politicized, you have seen nothing yet if we take the unfortunate route of making it universal. Letting the government have pell-mell control, all restraints off, they can do what they want with the healthcare system. You have not seen nothing yet. You will see a politicization of healthcare like you've never dreamed before. And you know what's the last thing you're going to get out of it? Actual healthcare. I think that's something we need to seriously think about. Do you really want the government, who can barely manage what it is managing right now, to have greater control of your health care? Do you really want that? Just think about that.
You've been listening to Rage of the Age. If you loved today's podcast, make sure to leave a review on the media you're listening through. Secure future episodes by heading over to rageoftheage.com and clicking the RSS feed button. Until next time, this has been Rage of the Age.